Welcome to the Morning Phillips series hosted today on YouTube. The Morning Phillips series, originally hosted at the Garage co-working space in Rapid City, South Dakota, was created to discuss philanthropy, civil society, and community. It is an opportunity to have a conversation with good people doing good things creatively and collaboratively. The format is a conversation, not a presentation, 2 tables, 2 chairs, 2 computers, and a community of interested people. Today we are pleased to have with us a rural healthcare expert, race car enthusiast, and grandfather. A special thanks to the Bush Foundation, the Numad Group, Rural Philanthropy Institute, and the Garage for hosting today's conversation. Thanks to all those who have joined us for over 70 previous conversations. Now, with all that, we are pleased to welcome Steve Long, President and CEO of Hancock Health, Hancock Regional Hospital in Indiana. Steve, thanks so much for spending time with us this morning and yesterday. I think you shared that last time you were in South Dakota, you were 4, and we hope after the pandemic we can invite you back and you can see some changes since you were last here. But thanks so much.
I would love to do that. It is a pleasure to be here with you, Pat. And I do look forward to the day in post-pandemic America where we can travel again and I can come to the Black Hills and see everything that's there. Because I only have one memory, and it was from 4 years old sitting on the back of a stuffed horse. So I look forward to other memories.
Maybe you were in Wall, at Wall Drug.
Because I do remember the Corn Palace. So.
Well, Steve, thanks so much. I know you're super busy running a hospital and a hospital system in rural Indiana. And thinking about how to start off this morning, I start with healthcare seems to be very much a business. Revenue comes in, pay expenses, you have money left over to do more things around medical, around healthcare. As the CEO of a system in a hospital, what does your day look like?
Well, what a great question. And every day is different, I'll tell you that. But at the end of the day, it's always looking forward to the next board meeting, right? Because I'm the CEO, I report to a board. You know what that's like. And the board wants to know how things are going. And typically one of the first things they look at is the financial statement. Because boards understand that if you don't have a margin, then it's difficult to support your mission. So that is truly part and parcel of what we do. We are a business, but we're a different kind of a business because we cater and we work in the space of people's health and their lives. And so that merging of the margin and the mission is so important. But yes, you're right. I mean, at the end of the day, we are not unlike any other business. We have price times quantity is the money in, and cost times quantity is the money out, and whatever's left over is the margin that you use to continue your mission. So we do focus on that. I think the underlying issue, though, in American healthcare is the incentives that are built into that margin statement, right? Because we are dependent on people being sick. And it hurts me to say that. And as a hospital administrator, I can tell you that one of my favorite times of the year has always been the flu season. Right? In a non-pandemic year, but the flu season, right? Because people are sick and their underlying conditions are exacerbated and they end up in the emergency room and in the hospital and the clinics. And we do all kinds of great care. We send people home, they feel much better, and then we send a bill. And that is the business model. And it is, unfortunately, we call it healthcare. It's not healthcare. It's actually sick care.
So I want to talk a lot more about that and about how what you've seen over the years in rural America and what you guys are doing differently in your community. But can we go back about 50 years? No, I think 1951 to start?
That was when our hospital started. And in fact, it was about 70 years. 70
years ago or so. What do you believe the idea was then when I believe a husband and wife donated the land to create the hospital and really led the way for the vote to create the hospital?
They did. So we can actually trace our origins back to the founders. It was the Andis family. So Fanny Andis was the wife of the couple. They actually lived in a house. I'm looking out the window and I can see the house that they lived in across the street. And this was in the early part of the last century. And she was pregnant. And it was in the middle of winter and she went into labor. Her husband put her in the car. They took off to the closest hospital, which was in Indianapolis at the time. They got stuck in the snow, had to turn around, came home, and she delivered her baby at home. And unfortunately, the baby died. And there were complications with the birth that she was not ever able to be pregnant again. And she decided that had there been a hospital in Greenfield in Hancock County, that would not have happened. So she made it her goal in life to get a hospital here. And she and her husband were people of some means, and they bought land across the street from their house, which was co-located with the county fairgrounds, and they gave it to the county with one requirement, and that is that they put a hospital on it. So there was a big vote, and 85% of the people in the county said, yes, we need a hospital. And so they began construction in 1949. And then in 1951, we opened as Hancock County Memorial Hospital. And I can tell you, we still have an inpatient unit named after Fanny Andis. It's the Andis Women and Children's Unit. And it that founding and that vision has permeated this place ever since.
Thanks, Steve. Thanks for giving us the history. And when you think of these 70 years, what's the biggest change in healthcare?
Well, there are a number, but I will tell you that back in the day, healthcare was typically, especially hospitals, was typically provided in faith-based institutions or governmental institutions, and it was really a charitable enterprise. That was how it worked, and the vast majority of the money that came into the healthcare system really came from patients. So they had a very direct connection to the decisions they were making. I think the biggest change that's happened is that we've become very much a third-party payer-based system. So that today, 88% of the money that flows into healthcare, especially in the hospitals, comes straight out of the insurance companies, and only 12% comes from the actual users. So I think that the incentives that have been built into the system, where the user is separated from the cost and everyone has divergent incentives, has built for us a volume-based fee-for-service system that is really focused on treating disease and illness after it happens, rather than preventing it from happening in the first place.
And how is that then, what impact has that actually then had? Because,
the cost has skyrocketed. So I can tell you, back in 1965 is when Medicare and Medicaid came about, and they were a cost-based system. And once healthcare providers figured out that there was a reliable source of payment, it opened the floodgates to really new technology, new medications, all kinds of things that really increased the cost of healthcare. And by 1982, there had been 17 straight years of double-digit cost increases. So, I mean, we think that this stuff is fairly recent, but in 1971, Congress passed the HMO Act because they said we have to get our hands around healthcare costs because it's just too much. That was in 1971. So in 1982, they changed the way that hospitals were reimbursed, and that slowed down the growth. But then we all figured out how to continue to provide higher and higher levels of care. And I will tell you, we live in the very best healthcare system in the world in terms of technology and learning and knowledge and medications and all of that. We are the very best, but we focus all of our attention on treating people after they get sick because that is the way the system was built.
well, so certainly, right, this then leads to the highest life expectancy and continued growth of high life expectancy.
Yeah, well, one
Just
would like to
leading
think
in
that. You would look at that and say, well, we spend $4 trillion a year on healthcare in America. Certainly that must be the case, but in fact, it's not. If you go back and you look at what actually drove the doubling of life expectancy in America, and it hurts me to say this again, there are many things I say that hurt me because it was not hospitals and it was not doctors and it was not pharmaceutical companies or insurance companies. It was simple things like sanitary sewers and toilets and clean water and hygiene and vaccines. It might be a healthcare related thing, and safe food and warm, safe, dry housing. I mean, these were the things that actually doubled how long we live, and it was all public health. It had very little to do with the healthcare system.
So Steve, can we pull out a little bit, because public health has been a big topic this last year, obviously with COVID. Can we pull out and talk about public health and about what you at the hospital are doing, treating, as you see, sick people?
Right.
Why is public health so important?
Yeah, so
what the
public
difference-
health. Yeah, you bet. So public health is really nothing more than understanding that it is better to prevent something from happening than to let it happen. And it's a very old concept, right? I mean, Erasmus back in 500 years ago, back in the 1500s, said it is better to prevent something than to allow it to happen. Ben Franklin jumped on and said an ounce of prevention is worth a pound of cure, right? So we know this. And the idea of applying this to healthcare, I mean, Hippocrates 2,500 years ago said it is better to know the person that has a disease than the disease a person has. So you put all these ideas together, and it's really all about prevention. Now, in healthcare, we're all about treatment, and we do a great job. I mean, if a person has COPD, so chronic obstructive pulmonary disease, lung disease, if they have heart disease, if they have diabetes, if they have many types of cancers, I mean, we can do amazing things. We really can, but it's all treating things that are highly preventable. And that I think is the thing that we have forgotten. And it is something that I'm hoping that we've learned during the pandemic, because you look at COVID, right? I run a hospital. We had many people here, and the treatments that we had were very inadequate. I mean, if you get COVID bad, there's very little that we can actually do for you. And the things that we did at the beginning, we learned were not probably the best things to do. We had a very robust monoclonal antibody infusion center. That was about the only thing that we could do, and there was a very narrow window when it would work. And that is why wearing masks and washing hands and keeping distance, that was what actually worked. And it's all prevention. It's public health. It is exactly the same things that our parents and grandparents understood back in the day. So, you know, when we went out to begin vaccinating people in our county, the first ones to really jump in line were the ones that were allowed, and they were the ones that were 70 and 80 years old. Mm-hmm. And not only was it because they were the ones most directly impacted, they remembered all of the communicable diseases we used to have. They remembered polio, they remembered measles, they remembered all these things. And they remembered when the vaccine came. And they said, it is way better to get the polio vaccine than to get polio and end up on an iron lung. So they understood. So there was very little difficulty with them taking the vaccine, because they understand the value of prevention. I'm hopeful that we have learned that again in some measure. I get less hopeful as time goes on, but that was my hope.
Steve, talking about the vaccines, and I was actually listening to an NPR story, I think this morning, or if not last night, and specifically talking about those that are not receiving it are mostly in rural communities, rural white individuals in America. Why do you suppose that is? And why has this become a political issue?
You know, probably the saddest thing that I have observed during all of this is how politicized it has all gotten. And it's not a political thing. It's a disease, and there are things that we can do to prevent disease. So why do I think that folks in rural areas are less likely to take it up? I think there's a couple of reasons. Number one is that fundamentally, as Americans, we're very independent. And the more rural you get, the more independent and self-supporting we are, and we're very proud of that, and we don't like to give up that independence. There's also, often a very healthy skepticism of government and academia. I think that plays into it as well. And then, my goodness, social media is such a purveyor, and I know we're actually talking on social media right now, so but it's such a purveyor of misinformation that it is difficult to know the truth. And when you hear people that seem to really make sense say very different things, and then you combine it with that independent spirit and that natural skepticism, I think you get where we're at. And it's going to take some time. It's going to take some time. I'm hopeful that folks get there, but I think that what it's going to take to get there are requirements. If you can't travel on an airplane without a vaccine, that's going to do it. If you can't go back to college, I think that's going to do it. If schools say, hey, the kids can't come back unless they have the vaccine. And people think this is unusual, but I mean, you know, kids get vaccines. I mean, your child has to be vaccinated for all kinds of different things. This is just another one. So in time, we'll get there. I think my biggest fear right now, though, is that we have such a slow uptake on the vaccine, and there is such a huge resurgence of the virus internationally. I mean, yesterday was the highest day ever. And India was shocking, 314, 15,000 cases. The opportunities for mutations are so big that I think it's very possible, and of course Pfizer is even talking about the booster shot now, that this will become just another one of these vaccines that we get all the time.
What has this past year been like for you? I think a couple months ago, if my memory is correct, when we were talking over a video, you were self-quarantining because you were exposed.
Mm-hmm.
How has this been leading a healthcare system? How we understand too, and you hear the stories and of how difficult it is in frontline work or for the frontline staff. And as we talk more during this hour, the approach that you lead, it seems, in Hancock Health is very personal, very community oriented. So I just imagine you were doubly hit with this past year. Will you talk a little bit about that and with us this morning?
Sure. So I will tell you that we are fundamentally blessed to be where we're at, and we were financially well prepared to go into something like this, so that made it much easier. I can't imagine what it would have been like if we were trying to meet payroll and go into this, but we were able to go to the board and say, we're going to stop doing all of the things that make money, right? We stopped elective surgeries. We stopped everything outpatient. We turned all of our physician practices into a virtual environment. I mean, that was amazing, right? We went in less than a week from 100% in person to 100% virtual. Now, in the intervening time, we've gone back down to about 7% virtual, but it peaked in there. So we said, we're just going to stop doing things that make money. And oh, by the way, we're going to start doing a lot of things that don't make money. We're going to spend a lot more money than we ever did before. We're going to go out there. We're going to actually give money to the fund that is helping to keep some of our smaller local businesses afloat. We're going to go out there. We're going to get food to people that need it. We're going to create a market inside of our hospital so that our own employees don't have to go to the grocery store. We're going to do all of these kind of things. We're going to buy masks for $1.50 for things that used to cost 5 cents. And we're going to do a vaccine clinic that's going to lose $1 million for us this year. Anyway, so we said we're going to flip our business model upside down. And it has had such a positive impact on our relationship with the community, which was already good. But they looked at us and they said, you know what, you really are all about us. You're not all about the money. So that was what we did. But I'll tell you that the culture that we have here supported it, right? So that story that I told you about Fanny Andis, kindness is in our mission and it's in our vision. In fact, our vision starts out with, we will be nationally recognized for kindness. And we have our unofficial motto, which I just need to make official now, is what a blessing it is to work in a place where we love people for a living. So we do these things. That's who we are. That's part and parcel of what we are. And so that allowed us to do things very differently. Now, I can tell you it was not easy. I mean, it's not easy going into the board every month and saying, well, we lost another $3 million last month. Hope that's okay with you guys. Mm-hmm. But, they were very supportive and we are turning it around again.
Can we talk about about kindness and
Sure.
Living our values every day is a phrase that I've heard you say and have read about. You've led, how long have you led the healthcare system, and where has this very clear message of kindness, where is this very clear living our values every day idea come from for you and for the system?
Sure. Well, I will tell you that living our values every day, if you look at it as an acronym, it's love. Mm-hmm. Right. So our strategy is simple. It's 5 words. Our whole strategic plan is 5 words. It's Medicare gap, which is all about this volume-based fee-for-service thing and how do we be successful there. Population health, which we're kind of talking about, and love. 5 words. I'm a simple country hospital administrator from Indiana. But when we look at it, And I will tell you, this is another thing we won't talk about, but about 3 years ago, we had a cyber attack, which was horrible. And I've been on the road for the last 3 years, kind of evangelizing other hospital administrators about the need for cybersecurity. But what we learned during that is that when you are a hospital, it is people taking care of people, right? That is what we are. That's who we are. It's not about making money. It's about taking care of other people. And we believe in the fundamental value of humans and human life. And that is what we're about. So it is not a stretch from that point to say, if we are all about people, and in fact, when I do new associate orientation, the very last thing that I tell them, it's the first thing and the last thing, is that if you remember nothing else from what I say, and I talk to them like an hour and a half, it is that everything we do is about people. If we don't ever forget that, we're going to be successful. So that was our approach during the pandemic. And frankly, that's our approach all the time. And that's our approach to saying that we want this to be the healthiest county in the state of Indiana, because we care about the people, and we want more people to come and live in this area and experience what we are experiencing. So it's fundamental to us that we believe in the value of people.
And how is that lost on other places? How is that not the focus? And when we think of, and we started off with, this is a business that you're running, but there is also a part of me, and it's a service that's being provided.
Mm-hmm.
And originally, if I understand correctly, of how medical services moved to the West and into many rural places, it was a lot of Catholic nuns a lot of times.
It was
really about serving the population that was moving into these towns, following railroads and mining, et cetera, et cetera. Mm-hmm. When did so you're going back to some of the tenets of the original mm-hmm. caring of other people. Where have we taken a turn with healthcare in general?
Yeah, when you look at most communities, especially in the West, the origins of healthcare are doctors on horseback riding from village to village or house to house, right? That was what it was. And they often got paid with chickens and with eggs. And I mean, very, very rarely was money involved. And the physician was regarded not because of their financial status, they were regarded because of their care for other people. And at the beginning, hospitals tended to be charitable institutions, right? They were religiously motivated. They were faith-based. They were governmental in some cases, but mostly they were faith-based, which is why you look at many hospitals today and they are St. Luke's or St. Michael's, or they're the Methodist hospital or the Lutheran hospital, right? Because they were started for charitable reasons, because people saw the value in providing care to other fellow human beings. I think what happened is that we developed a system where it became very focused on money. And again, we have $4 trillion a year going into the healthcare system. In 2018, 60% of all the new IPOs on Wall Street were healthcare related, because there is so much money inside of this endeavor that we have now. And unfortunately, we all respond to the incentives that we have. And if the incentive is financial, then you're going to work out a way to make money at it. And you do have to have a margin, right? There's the old saying in healthcare, no margin, no mission. It's true, right? You can have the best mission you want, but if there's no money to support it, you're not going to be doing the mission. But we have gotten so far down the road where we have separated the incentives and we have separated the actual transaction of care from the provider and the patient. And we now have employers and we have insurance companies involved in that mix, and their only incentive is financial. And that's how we got to where we're at. And I think that's fundamentally the problem here. And I think it can be fixed. And we have some models that are trying to fix that.
And you guys are doing it, because as you guys have created a model, and you've been leading this for a number of years. Will you talk a little bit about what that model is and the care that you're providing, the holistic approach to this? Before we jump into that, Indiana has joined the exchange. It has expanded. Mm-hmm. Can you talk a little bit about that? Because South Dakota struggles with that concept, even though I think it's been calculated numerous times that this would be a net positive for South Dakota with more resources to provide healthcare. We talk a little bit about that. There's a question from one of our city council persons specifically on Medicaid expansion, Steve.
Sure. Yeah. So Indiana was late to the game in Medicaid expansion, and they took a slightly different approach with it. So there is a very kind of a work-based approach. It was an expansion of something called the Healthy Indiana Plan, which is a portion of Medicaid. But it really worked in Indiana because the hospitals stepped up to the plate, and there is a provider tax that is associated with this. So the hospitals provide much of the state's match to get the federal monies to come down. So it was the healthcare industry that really, I think, didn't force but encouraged the state to go down this path. I think, though, that when you do the math, I mean, you hate to say it's math, but it is, that the ability or the willingness of the federal government to pick up so much of the tab for the Medicaid expansion is what makes it really make sense. And for the hospital's perspective, it takes people off of the role of true charity care, where we know that we are delivering the care to them with nothing in return, and it at least gives some level of reimbursement. And if you have other mechanisms like we do in Indiana, that Medicaid reimbursement can approach Medicare levels. So it makes sense. Now, the thing that you have to get past, though, and I get this, right? Because Indiana is a very conservative state. Potentially, you would be shocked, maybe even more so than South Dakota, because we have a Republican governor, we have super majorities of Republicans in the Senate and the House, and there is not even a Democratic Party in my county.
Wow.
So it's a very conservative state, and yet we did the Medicaid expansion because we could see where it made sense, and there was a way to fund it that did not rely on tax revenue to people. So that I think is how we got past it. Do I think it's a good idea? Yes. Right. We have a healthcare system that requires people to have insurance, and one of the problems that we have in healthcare is that it is so expensive that unless you are independently wealthy, you cannot afford to seek treatment for a disease or an illness or an injury that you might have. So insurance is required.
Thanks, Steve. If we specifically talk about the health system and the focus that you have had in creating this holistic approach, and what is so impressive, how the community has you've led the community in doing this. We talk about what it is, where did this idea come from, in the blue zones, and how you've applied that to your county of 80,000 people?
Yes, it is. Yeah, so I will tell you that I am originally and most recently from Iowa. I didn't mention that I actually have a South Dakota connection. So my grandmother was from southeastern South Dakota. Back in the early 1930s, my grandfather drove from Oskaloosa, Iowa in a Model T. And I can't even imagine how he did it, right? Because there were hardly any roads back then.
Interstate 90 didn't exist.
It did not. I think there was some kind of a cow path that went from Sioux City over to the other side. And anyway, he drove to South Dakota and married my grandmother and brought her back to Iowa. So that's my South Dakota connection. Anyway, so I was running a rural hospital in Iowa outside of Des Moines, and we were in the running to be one of the communities that was going to be selected as a blue zone community. And it was a partnership between the state of Iowa, Walmart, Blue Cross Blue Shield, which I think you guys have in South Dakota, and the Blue Zones Project out of Minnesota. And we unfortunately did. Yes, go ahead.
Can we do the blue zones?
Yes.
30 seconds?
Sure. So the blue zones, Dan and Tony Buettner are the ones that kind of created that concept. And they looked at the places in the world where people live significantly longer, healthier lives. And they looked for the reasons for that. And it comes down to about 4 categories that are common sense, right? They eat differently, they move more, they have different kinds of relationships, they have a different spiritual focus, and there are subcategories too. And they said, if that's what it takes to live that long, does that mean you have to live on an island in the middle of the Mediterranean or on Okinawa or in Loma Linda, California? And they said, no, you can apply those learnings. And so they have a blueprint for applying those into the smaller communities, especially. Albert Lea, Minnesota is one place that they did that. And so I was introduced to the concept there. We were not picked as a community for that, but I was fresh off of that effort when I came to Indiana. And I was thinking about that. And I have always been involved in economic development as well. And it occurred to us that economic development used to be about attracting employers. And now it's about attracting people. Placemaking is the key to economic development. And when you look at quality of place, it's a lot of things. It's how good is it to live there, and healthcare is fundamental to that. And in fact, the health status of the people is really key. So here's a little story. So a international auto manufacturer opened up shop in Kentucky, and they got all kinds of economic incentives, and they opened up a big plant, and they started hiring people, and they figured out on the first day that the people were not healthy enough to actually work a full day on the assembly line. And so they began doing, in fact, paying their people to do fitness exercises and do all kinds of things to improve their health status so that they could actually do the work on the assembly line. And one of the learnings that is out there now is that you need to look at the health status of people, because if you're going to go into a community, you not only need to know that there are enough people to work, but they are physically able. Anyway, so we said this is really an economic development thing along with a health thing. So we brought in the folks from Blue Zones, and we looked at how we might do that, ultimately decided to partner with the Mayo Clinic and the Wellness Council of Indiana, and developed a blueprint for making Hancock County the healthiest county in the state of Indiana. And it had a number of components. It had a whole, and I'm sure we'll touch on these as we go, but it had a whole component about the environment, another component about that we are more than just our bodies. We are mind, body, and spirit together. How do we function that way? There was a whole component also about really understanding that we need to manage the care of people that are in the midst of a chronic disease differently than we had ever done before. So we put all that together into a blueprint for our county, and it has been really quite successful.
Will you take us through that? How many years has that, when did you start this, and what were the steps that you led?
Sure. So we started this back in 2015. I've been here about 7 years. So it was about a year after I got here. And we built on some of that same thinking. So, I will say to everybody that there are 3 ingredients for success in any endeavor. It is geography, timing, and everything else, right? So right time, the right place is really important. So that was a piece of it. But we first said internally to our organization, we need to look at people differently, right? Because the business model, and if there are healthcare people that are listening, I hope not to make them feel too bad, but it makes me feel bad when I say this, but it's true. The business model for hospitals was Mrs. Smith. And Mrs. Smith is an 85-year-old woman that has congestive heart failure and is a frequent flyer in the ER. And she would be short of breath. She'd come to the ER. The physician would say, "Oh, Mrs. Smith, it's the fluid buildup. We're going to admit you to the hospital. We're going to give you some medication. Get that fluid off. You're going to feel much better. A couple of days, you're going to go home." We would do that. She felt great. We would send her home. 3 weeks later, she's back in the ER. Exact same issue. We'd admit her. She would feel better. 2 or 3 days later, we would send her home. Every 3 weeks, she was back in the ER. And every time we treated her very, very well and made her feel better and sent her home, we sent a bill. Right? So that was the business model for hospitals for a very long time. And in many cases, it still is, until the incentives began to change right about that same time. And it was Medicare saying, we're not going to continue to pay you every 3 weeks for Mrs. Smith coming into your ER. And then they said, we're going to get you into an accountable care organization where we will actually incentivize you for Mrs. Smith not coming into the hospital. And when these things happened, we said, we need to take a different approach. So we hired care coordinators and transition of care managers, and we have people now that go out to the homes of our patients. So they go out to Mrs. Smith's home and they say, "Mrs. Smith, you live alone and you have a dog and you don't breathe well. And you actually have a little bit of asthma too. And there's a hole in your roof and there's mold up in the attic and you have stairs getting up to your front porch. You need to have a ramp. And what are you going to do about this?" And Mrs. Smith says, "Well, I can't afford to do any of that." So unlike any time in the past, we now find the people that build the ramp and fix the roof, and we put a medication fridge in her kitchen so that her diabetes medicine doesn't go bad. And we are actually in the home with Mrs. Smith, actively keeping her out of the ER. And we're incentivized to do that. So that's one piece of it, is that we have embraced that. Another piece of it is that we have said we need to partner directly with employers and not insurance companies so that we can be reimbursed ourselves on the premium dollar, which changes our incentive away from treating the patients and to keeping them healthy. So we're actively trying to change our own model. The second piece of that then is, of course, we are mind, body, and spirit all together. We are not just bodies. So we have a system of care. And it was really something we put together with all of the not-for-profits and education institutions and law enforcement and government and everybody to say, how do we create a true safety net around people that are especially struggling with mental illness and substance abuse? And how do we focus it? And we did at the beginning on young families, because you try to change somebody like me, I'm old, right? It's hard to change me. But if we can intervene in the life of a child or a young family, we'll change their family tree forever. And so we are in that business. And we have a congregational health network where we actually have more than 30 churches with covenant partnerships with our healthcare organization. And their parishioners can be members. So when Mrs. Smith shows up in the ER, we know that she is a member of our congregational effort and Park Chapel Church. And we say, Mrs. Smith, would you like us to call the church? So we do that. And they say, well, we didn't know Mrs. Smith was in the hospital, because, they never know. And they say, she lives alone and has a dog. We'll watch the dog and we'll put her on the prayer list, and we're going to deliver meals to her when she's at home. So it's an extra layer of love. And then finally, it is the fundamental understanding that the choices we make are highly correlated with the choices we have. And so if we don't have walking and biking trails and sidewalks, then we are not going to walk and bike in this community. If we don't have healthy food options, we're not going to choose them. It is changing the environment that we live in to nudge us into making the healthy choice, not the unhealthy choice. That's a very brief overview of what we've done. So we started that about 5 years ago.
What has been the biggest challenge in that?
Oh, the thing is that much of it has to do with public policy. So especially the healthy environment component, and convincing elected officials that this is a worthy use of money is a big challenge. Convincing people that it is important to create incentives for ourselves to help us make healthier choices, that's difficult as well. Let me give you two quick examples. So smoking, I will tell you, if there was one thing that we could do in American society that would have the biggest impact on healthcare and on health status, it would be to get people to stop smoking. We could do nothing else than that, and we would be in great shape. So we became the first hospital in the state of Indiana to prohibit smoking on our campus, or tobacco use in our campus. Our county became the first county in the state to prohibit smoking in public buildings, and that was actually before my time. Just a couple of years ago, we added no smoking in public parks. So that's a big piece. But going to the county commissioners and explaining the value and actually getting them to buy into it, that's a big deal. And then the other one is that we actually have a trails plan county-wide, so we know where every single trail is going to be and every single sidewalk in our county, and it is programmed into the county comprehensive plan. So we've had a number of different organizations in our county working together to put that together, get it into the comprehensive plan, and then to implement it. So now as development happens, those things are getting built, and in 20 years we will have a fully functional trail system in our county, because we made that choice 5 years ago.
I really like that last one. I think Sioux Falls, on the other side of the state here in South Dakota, has a very similar, I understand, program where they're tying all the what will be a whole loop around the city as it's developed, and it's the burden of, it's on the cost goes to the developer. It's part of built in to develop that land, and it's a benefit to everybody.
Yeah, it absolutely is. I've talked to many of those developers myself, and they're more than willing to do it if it's part of the requirement. If it's not part of the requirement, they're not going to do it.
You touched on this a bit, and we're talking a little bit right now about social determinants of health. Can you break that down for us, and then how Hancock County, how you are at Hancock Health are really working on those determinants?
Yeah, you bet. So let me first say that an easy way to think about the social determinants and the impact they have is that there have been many studies that have been done looking for the magic number. And it would be the magic number that is most highly correlated with life expectancy. And they have found it. They found it a number of times, and it is always the same number. And it is not BMI, it is not cholesterol count, and it is not anything else. That number is your zip code. That is more highly correlated with life expectancy than anything else. And I'll give you an example from here in Indiana. So in downtown Indianapolis, there is a trail It's called the Monon Trail. It's on one of the old, right?
Yeah.
And it runs from kind of downtown Indianapolis out to the north side, which is the very wealthy part of the Indianapolis suburbs. The difference in life expectancy from the south end to the north end of that trail is 14 years.
Yeah.
And it is incredible when you look at that. So really, social determinants have a lot to do with where you live, which is your economic status. I mean, that's really what that's about. And so we see things like, well, for example, we often will find that if a child has issues with asthma and live in a low-income area, and they live in substandard housing, that has a bigger impact on their asthma than anything that we do as healthcare providers. So helping that family find a different place to live. There are even some hospitals, usually they're the inner city public hospitals. In fact, there's one right here in Indianapolis that does that. They have their attorneys go after the landlords to ensure that housing is not substandard, because they find that it saves them money in the long run, because they are paid basically, well, mostly they're not paid. They're supported by tax dollars. So their incentives are really to keep people out of the hospital. And so we apply some of those same learnings here. So for example, food is medicine, right? We're a big believer that food is medicine, and that you can work out all you want, but 90% of your health status is going to be driven by what you put in your mouth. And that is a hard thing to do. So we have actually done a number of things in the food as medicine space. So we had a program for quite a while that we're transitioning right now into a different direction, where our physicians had the ability to write a prescription for nutritionally disadvantaged and economically disadvantaged patients to go to a place that we had set up, get a whole bag of fresh produce, and they gave them basically the prescription, and the person would provide $1 just so they'd have skin in the game. And we began to do that. We then kind of morphed it into a way where we were using an internet-based kind of a farm-to-table approach with a segment of our population that were really pregnant moms and the cancer patients. And now we're morphing it one more time. We also have wellness centers. So we have these. You want me? Can I go into the wellness center thing a bit?
Absolutely.
Okay,
Please.
So we have a really unique approach where we have 3 buildings, 3 different places in our county. They're each about 50, 60,000 square feet. And if you drove up to the front, walked in the door, you'd say, well, this is a really nice gym, because it kind of looks like a gym. But what we have in there are our rehab. So physical therapy, occupational therapy, that's all there. We have diabetes educators there. We have exercise specialists. We have all kinds of folks, and we do a medical fitness approach. So for example, our doctors will write a prescription for a patient to go to the wellness center, 60 days for $60, so it's $1 a day. And they meet with an exercise specialist who goes through a fitness analysis with them that looks at nutrition, looks at their physical fitness, and then creates a regimen for them. And then they help them get on it. They monitor their progress. And at the end of 60 days, there's almost always an improvement. And then those folks usually become members of our wellness center, and they continue that journey. And it's all very technologically supported, and it's kind of cool how it all works. Similarly, when you have rehabilitation, you go to the rehab clinic at the wellness center. And as you probably know, insurance companies pay for less and less rehab all the time. And so our rehab therapists will use that same equipment for the folks getting rehab. And at the end of their paid time, they can become members of the wellness center, continue using the same equipment. The therapists are still around, and they continue their journey. So we really try to get people into the resources, or get the resources to people that will help them address these fundamental issues that are driving them down a path of chronic disease, because that's really what the problem is chronic disease.
When you think of the 7 years, you think of the what you have led. What's the single most important decision going down this path that you've led?
Yeah, the most important decision was to start. And I hate to say it because it sounds a little, simple, but it was true. You have to start. And in many places, they get so wrapped up in the analysis that they never start. So we said, we're not exactly sure what this is going to look like. We know the fundamental pieces of it, so let's just start, and we will change as we go. And so we did that. So that the key for us, kind of going back to that Blue Zones thing, is that we said we need the blueprint. So how do we get the blueprint made? So we partnered with the Mayo Clinic, the Wellness Council of Indiana, Ball State University in Muncie, Indiana, and we put together the blueprint that would allow us to do things that made sense and that we could put money into. And I'll tell you, my board is so visionary. I am blessed with a board. I use that word a lot, blessed, but we're blessed with a great board. And we actually, we have some kind of unique income streams that we've developed over the years. And they made a commitment, and they said, we're going to take 10% of those unique income streams, and we're going to put it into this effort, almost a tithe, right, to support this community enhancing effort. And so that's how we have been funding this. So, we're blessed to have done that.
How has the community responded?
Oh, well, so I'll tell you a story. We started this thing, we call it Healthy 365. So if anybody wants to know what we've actually done, Be Healthy 365, all one word, .org, and you'll see everything there. Anyway, we called it Healthy 365, and it had a number of components to it, one of which was the system of care. And this is like 50 of these organizations that get together regularly to really coordinate efforts, right? So that we don't duplicate things and that we can really help the people that we're trying to help. Because we often find that there's one agency that does one thing and another that does another, but they never talk. And so the families that need the support of both never got connected to both, but now they do. Anyway, so this has been going on for several years, and I was at a meeting on the community. This would have been late 2019, before the pandemic, and I was sitting next to a person, and we were just chatting, and they said, there's this thing called Healthy 365. If you've never heard of it, you really should learn about that, because it's quite a movement here in Hancock County. And I thought, wow. It's not even affiliated with us apparently anymore to the community's mind. It's a movement of its own, which is exactly what it needed to be. So that the community has been ever so supportive of this.
I really appreciate that. And that you see that as a success. And you mentioned some unique or innovative revenue streams. I think there's in some of the material, and you can find that you guys are you've backed a number of things that have also allowed others to rise and to flourish, that ultimately may be that benefit financially, but it's allowing other community members, other community businesses to have the footing to be successful. And I think that's true leadership. And I am wondering, when you think of leadership, what are the characteristics of a leader? What is it that, and has that changed before the pandemic and in this last year? We talk a little bit about leadership.
Sure.
Thanks.
So I'm a proponent of a concept called servant leadership, and that is really understanding that the role of the leader is to serve and to support, and to not be the one that's out there, kind of the face of the organization. That happens, right? I mean, especially during the pandemic, that has happened because the community needed a face that could be trusted for information. And so they turned to us, and that's what we did. But truly, it's servant leadership. It's saying, this is not about me. This is about our community. And it's easy to do that, right? Because I have grandsons, and I will tell you just a bit of a trail here, rabbit trail. But we have a very unusual living circumstance because my wife and I were almost empty nesters about 2 years ago. We were thinking, wow, what's that going to be like? Everybody's going to be gone. And fast forward to today, and we now have my 88-year-old father-in-law, my oldest daughter, who is 29, and my two grandsons that are 5 and 7 living with us. So we have this really interesting dynamic at home. But, my grandsons live here, and hopefully they will continue living here for a very long time. So what we do today is going to have an impact on them and on their kids, right? And there are unique moments in time and in history for every community. We happen to be in one of those right now, where we know the decisions that we make will have a generational impact. And that's what we need to be thinking of. We don't need to be thinking about our success or what does our balance sheet look like next year. We need to be thinking about what does this community look like 10 years, 20 years, 50 years from now. And those are the kind of decisions that we can make. And it feels good, right? To be able to say, hey, we're not just making a difference on a daily basis for patients, which is wonderful. we're making a difference for the thousands and tens of thousands of people that will live here forever. So servant leadership, I think, is key. Part and parcel to that, we talk about living our values every day, which is, I mean, that is what we're all about, living our values every day. And it is that love thing. So I'll tell you how we programmed it here. So we actually have something called the love promise. And we say, if we really believe in these ideas, right? So our values are fundamental to what we do. And they are that we will be exceptional, and we will be honorable and devoted and reliable and kind. So those are statements about who we are, what we will be. And if we really believe that, then there are certain ways that we will interact with each other and with our patients and with our community. And we actually list those out. We say, these are the behaviors that we expect from each other, and we sign it. I've signed it. Everybody who works here signs it. And we are committed to this idea that we will be devoted to those values. And those values are not about us. Those values are about people, right? Because everything we do here is about people. And so when we look at our motto, and it is, what a blessing it is to work in a place where we love people for a living, we have codified that into everything that we do. The love promise, the strategic plan has that in it. And that love is an acronym for living our values every day. So it all comes together. So we say that the focus of the leaders here is to implement that idea. Everything we do is about people.
Steve, when you've been the CEO for years, you've held other leadership positions. Along the way, there must have been people that you had run across that were mentors. Is there a mentor that you would share, and why?
Yeah, I've got a couple. So the one that I would hold most dear, his name is Dave Brown. I'm sure he'll probably never see this, but if he does, Dr. Brown, hey, here's a call out, shout out for you. So I had not mentioned, I was actually in the military. I was in the Air Force for a while. My first job out of the military was working at the University of Iowa Healthcare, University of Iowa Hospital. I was a department administrator, and Dr. Brown hired me. And he actually had been in the Air Force way back early in his career as well. And he had gone through Mayo, and I went down and worked with him at MD Anderson Cancer Center. He ended up at Cleveland Clinic. But he is one of those, right? And he was able to speak into my life at really fundamental times of decision making for my career. And he modeled for me many of these things that I believe. And it has been a pleasure to be able to have people like that in my life. And one other guy, Tom Thoralt. I don't know if Tom will ever see this. He's a hospital CEO in Lincoln, Nebraska. And I worked for him, and he was one of the best bosses, and he also embodied those same values. So I think mentorship cannot be overstated. And having the right mentors, ones that are focused on people, that's what counts, not the ones that are focused on the bottom line.
And how do you and you in your servant leadership, and we've talked in the past a little bit about how some of the approaches in the community to bring people together, and it doesn't always include the people with the titles, as you have shared candidly. Can you just talk a little bit about the realization that maybe folks that are on the ground working in a different way than the CEO or the president or the executive is working?
Yeah.
Can what they bring to problem solving and visioning? Sure.
So let me first say that I understand that I have this thing I call CEO disease. And it is that I'm not always right, but I am rarely uncertain. So it is a disease that many leaders have. And it comes from being older and having gone through lots of things. But the fact is that as I've gone through my career, I have learned that at the beginning of my career, I couldn't see the forest for the trees. Now I can't see the trees for the forest, right? So I really don't know how things work on a day-to-day basis. And yet we'll get into a meeting, and because of my status and my title, people will just defer to whatever I say. And I don't know what I'm talking about, right? I mean, I kind of have an idea, and I'm old. I got, well, I would say gray hair, but I have no hair anymore. You have nice hair, by the way. I wish I had some hair. But the fact is that they defer, and it's easy to let that happen. So the only way really around that is to say the people with the titles need to not be in the room. And so we have a particular project that we're doing right now. In fact, the outbrief is tomorrow. And we made a deliberate decision at the beginning that the people with the titles would not be on the team, and that the people that are on the team are the ones that are most closely involved and engaged in the processes. And this is a community-wide process. This is actually about mental illness and substance abuse as it relates to the judicial system. And so I'm looking forward to seeing how that comes tomorrow, but I can't help but think, and in fact, I've seen some of the interim progress reports, and I know that it would not have been as good if the people with the titles were actually actively engaged in the process.
Steve, we only have about 5 minutes left, so I want to run through a number of questions. So we'll just try to do really quick to get some perspective, and to correct me if I'm wrong. 10%, 80% of all medical costs are associated with 10% of the population.
Yeah, it's true.
3% actually equal 50% of all the costs.
That's about right.
In 1930, there were 3,000 people over the age of 85.
Yeah. Yeah. And there's 7 million now, right?
Yeah.
It's huge differences.
Today we have, for every physician, there are 8 clinical support staff and 10 non-clinical.
Yeah. That the growth
18 to 1.
Yeah, it's incredible. I mean, the insurance industry alone has 2.5 million people in it.
Healthcare is the largest employer in the United States.
It is.
60% of the IPOs, you've said this today, 60% of IPOs in 2018 or 19 were associated to healthcare in some fashion. In 2035, we'll have more adults than children in our country. What does that mean?
That is one of the most worrisome things, right? Because we've moved from the population pyramid. We probably ought to remember, or I can, when I was a kid, go to school and there was a population pyramid, right? Small on the top, big on the bottom. It's not a pyramid anymore. It's now a pillar. And in fact, it's getting to the point where those that are over the age of 65 will far outnumber those that are under the age of 18. So the thing is that we become a society where we have a lot of people that need support, because as we get older, we get sicker, right? And we need that support, and there will be less and less people to take care of them. And you worry about the productive capacity, right? And I know as I get older, I cannot do the things that I did 30 years ago. I mean, my goodness, my 88-year-old father-in-law, he loves to go out and rake the yard, and we do things out in the woods together to kind of clean up our property. And he says, I just can't lift this thing anymore. I said, well, look, Dad, the difference between you and I in age is the same as the difference between me and a 27-year-old. I mean, I can't do the things a 27-year-old does. So you looked at productive capacity, and then you also look at the burden that the aged put on society, which is true. And I worry about just the economics of what it's going to look like. I mean, they're already experiencing this in Japan, and it's coming down the pike even in China, which we don't fully understand. And this is a big deal. But in terms of healthcare, the older we get, the more chronic diseases we have. And that's what really drives the spending. And unfortunately, they are by and large preventable.
Well, right? and I think a flourishing society is a young society. And one of the ways that the United States has always been able to continue to have that innovation and growth and stuff is because of immigration.
Yes,
and being welcoming, and also being the place that people could come safe and have the environment, education, healthcare to flourish and to be fully, authentically themselves, coming from other places around the world. Here's a quiz. It's off a presentation you gave that I saw. If toilet paper increased the same rate as healthcare costs, what would a roll of toilet paper cost today?
It's huge, isn't it? It's amazing. Like $100. I mean, things are. If you applied that rate of inflation from healthcare to what we buy at the store, there would be mass rioting everywhere, right? We would not put up with it, and yet it happened in healthcare.
So you mentioned a couple times they're the numbers.
Mhm.
How much has Hancock Health put into this approach that you've led? What's the net? Where does it net up?
So we put in, let me do the math. We put in right at $2 million a year into this.
And what's
So
the
5
benefit?
years.
What are you calculating as the benefit in the community?
Oh, well, so I would say the benefit to the community is priceless. I would say the financial benefit to our organization is minimal, right? Because this is not, we don't do this because we think it's going to have an immediate financial impact. It's not. It's a generational thing, right? It's 20 years to see the impact of some of the things that we're doing, which is why we're trying to set ourselves up as an organization to benefit from different incentives where we actually will get incentivized financially for keeping people healthy rather than for treating them after they're sick. That's why population health is a cornerstone of our strategic plan.
Steve, thank you so much. We've hit an hour, and I know people are going into work, and but really appreciate your time. And I do hope as we continue to manage the pandemic as a country, and when travel's safe, it would be wonderful to have you here and to continue this conversation. Thanks so much for this morning.
Thank you so much for the invitation. I look forward to coming to Rapid City. It will be the first time since I was 4. It's going to be great.
Have a wonderful rest of the day, and thanks everybody for joining. There's a survey in the comment box. Please take a moment and fill that out. And Steve, have a great rest of the day. Thanks so much.
Thanks a lot, Matt. You
Bye
too.
now. Bye-bye.
Bye.